So we're going to talk a little bit about what's new in the hip and how we can really preserve what we have and keep it. And so it's orthopedics, so it's not brain surgery, and it's not rocket science. It's pretty simple. So we do two basic things in orthopedics. For any joint, I would say, is when you come in, you have pain and dysfunction. We try to improve that. We try to get you back to doing the things that you want to do. And then the second goal in all that is for you to keep your joint and really to limit any arthritic change in that. And so if you look down here at the bottom, this is a perfect hip joint, right? Balls here, sockets here, and there's this nice big space in between. And really, what we're trying to prevent is this, when you totally lose the space and the joint becomes totally arthritic. Because the only solution for that is metal and plastic. So much of this talk is just preventing the slide on the left to going from the slide on the right. So here are our main players, right? The ball and the socket. So the ball is your femoral head, the socket's your acetabulum. And what's most important in the joint, obviously, is the cartilage. And that's just that low friction cap that's on the ball and the socket. And that allows you to move very smoothly and very fluidly. And when you lose that, that's arthritis. So the other really important structure is your labrum, and that's just the soft tissue extension out of the socket. And it covers 270 degrees around the socket, and it's intimately meshed to the cartilage. And the labrum is really important. And what it really does is it serves as a seal between the ball and socket. And so much like a gasket in your car or a washer in your faucet, it really holds the fluid inside your hip. And that fluid is really important. That's how you get nutrition in your cartilage. It really disperses the pressure, so there's really no abnormal loading on the cartilage, so it doesn't wear it down or tear it. And then secondly, it really seals the ball and socket together. It really holds the two together, so there's really no abnormal toggling between the two, so there's no abnormal stress that might damage the cartilage over time. So what we've learned over the course of time, and what's really a little bit of a new frontier, is there are really some subtle causes of pain and dysfunction in the hip. And in particular, there's this femoral acetabular impingement or hip impingement. And if you ever know why doctors write messy, it's because none of us could really spell that femoral acetabular impingement thing, so you just scribble it down. But the basic premise of this is just the ball and socket in some people just aren't perfectly shaped. And in some people, there's just a little bit of an imperfect shape. And as you go through a normal range of motion in the hip, they may collide because they're not perfectly or intimately matched together. And what happens is, as that happens, you may see tears, or it may produce tears in the labral tissue, and as the labral tissue is intimately meshed to the cartilage, you in turn get damage or progressive degeneration in the cartilage. And it's really not the hit of the bone that's painful, it's the labrum. That's where the pain fibers are, and that's really what hurts people. So in hip impingement, there are generally two types, and one that comes from the ball and one that comes from the socket. And so if you look up on the top picture, so here's the ball, and the ball should be perfectly round. It should be a perfect circle, and it should really be light bulb shaped as it meets the thigh bone. So you kind of see this nice light bulb shape. What we'll see in variations in some people is where the ball, particularly in the front, is more oval shaped. So you lose that really round essence of the ball. And as the hip rotates, it really can't fit in because it's not perfectly circular. And then if we look at the socket side, we call it the pincer. And what that means is that there may be a portion of the socket that's a little too deep. And it may be the whole socket, maybe globally deep, or more commonly in people, it's the front of the socket. And so you kind of get this overhang of the socket, and it is, again, as you try to go through a normal motion, the ball and socket hit. And so if you look on these diagrams, the bottom is the bump on the ball. And so if you look at a normal hip down here, as the ball rotates in it, it clears the labrum here in the cartilage, and it's free with motion. As we see some of these more oval shapes of the ball, as they rotate in, you see that bump kind of drive the cartilage in and push the labrum out, and it splits and tears the two. Now, it happens a little bit different when the socket is particularly deep. You'll see, here as it rotates in, it really clears the labrum and the cartilage here. If the socket is particularly deep, as the hip moves, it will crush the labrum in between the ball and the socket. And you tend not to see as much cartilage damage with that as that you do with a very prominent or non-round ball. So this is how we see it. And so, I'll see a lot of patients come in and say, yeah, I got x-rays, but they told me they were normal. And that is true most of the times in regards to the space between the ball and socket. And I think when we've all traditionally looked at x-rays, you say, well, it doesn't look like there's arthritis. You've got a nice space there. But really what we've come to find, it's these little subtle shape differences. And what you can see is that on the bottom side of the ball, so the back of the ball, it's nice and round, and there's a nice light bulb shape. And then we look at the top, and there's this hump. We see a much more oval shape. We've lost that light bulb shape. And secondarily, we look at the MRI. And, the MRI is really good. It tells us a very significant amount of detail about the soft tissue, so the labrum, the cartilage. We still can see the bone issues. If you look in the front of this, here's the ball. We see in the front, it's less round, more oval shape. But if you look at the arrow, we see more of that little dark dot or triangle in the front. That's your labrum, and you see the white split in between it, and that's a tear. It should be intimately meshed to that gray cartilage next to it. And probably the best MRI we have is with dye. I mean, you certainly can see tears without it. That's what most of our radiologists are comfortable seeing. But MRI is definitely either with or without contrast is not perfect. And there are certainly some small tears that we don't see that show up, or some early cartilage damage that really doesn't show up there. So really the gold standard to see it is to look directly at it, and it's with the arthroscopy. And so if you look, this is looking into the socket. This is the front edge of the socket. This is the ball. This rope, here's your labrum, and you see this hole where there's a tear away from it. So, we're talking about, these new frontiers. I mean, hip arthroscopy has been around since the 70s, so there's nothing particularly new, although it's really been slow to develop. In the 70s, I think they got in, they saw some white and high-fived, like we were in there, we saw it, okay, let's replace the joint. And it's particularly been slow for a couple of reasons, and one is really, we haven't really understood these subtle variations in the ball and socket and what causes pain. I think traditionally it was always, you got a groin strain, or you have groin pain, but your socket looks normal, so there's probably a little bit of a strain around the hip, but you don't have arthritis. And so part of it was figuring out what are the causes, and then secondarily, the hip is deep. No matter how big or small you are, your hip is the biggest thing you have around your body. Much different than a shoulder or a knee, which are very easy to access. And really, for a long period of time, there weren't great instruments to access the hip and to do it in a minimally invasive way. So really in the last 5 to 10 years, we've seen a real evolution in this, and it's particularly because we understand what the problem is, and we can kind of see it before it degenerates in some scenarios. And then two, we have better skill. We kind of know what we're doing a little bit more. We have better instruments to access the hip. So arthroscopically, what we can do is we can take care of all these things. So the cam, the bump, we can reshape it. We can make it more light bulb shaped. The overhang of the socket we can remove in small portions. The tear of the labrum we can fix. We can put anchors in the bone and suture it back. And then the cartilage injury, sometimes we can catch it before it really gets injured, and we can actually repair some of that. And much like what Dr. Delas talked about, there are some scenarios where you can regenerate some of the cartilage around the hip. So this is it. This is kind of what we're able to do in the hip, and we can put through some small needles and small incisions. We can introduce cannulas, and we're able to get into a very deep place, which we had to make big incisions to do through some very small incisions. We're able to do this, looking with an X-ray, and then once we've kind of accessed it, we can put the camera in and really get a picture of what's going on. And as you kind of establish that access, and now we're kind of looking, I've got these two little poke holes here, and I can see the camera up here, and I really can see inside the joint of what we're doing. And the nice thing, as opposed to where we once did this with dislocating the hip and looking globally around it, we're able to do it and really get a kind of a in vitro look of the way it looks normally. So what you're kind of going to see is the probe coming in, and as it looks up a little bit at the screen, I'm going to be pulling on a tear right here. And this is it. These are these two little poke holes that we do, and we can get a lot of work done through it. So this is what we see, and so there's kind of an evolution of things that happen. And so if you look, this is the ball, here's the socket, this is the labrum in the front, the band of tissue, and I'm pulling right in the middle of a tear. And you can kind of see where that labrum is torn away from the cartilage. There's not a huge injury to the cartilage at this point. You can kind of see as we go up and around the socket, we're pulling on the labrum, and all the labrum's fine. And then you can look over the top of the edge of the socket, and you can see the outside of the socket where there may be prominence there. What's interesting is sometimes we'll take the same look and look ball, socket, and we'll see the labrum here. And what you'll see is there's no tear, but as I push on the labrum, you'll notice the cartilage moves here. You can kind of see this little bubble moving back and forth. And it's actually like the carpet. You get a bubble in your carpet, you can get a bubble in your cartilage. And that's really kind of what we think is early cartilage damage. There's been contact there. They haven't split and torn yet, but because of the contact, the labrum and the cartilage have started to peel away from the bone. So this is like the earliest damage. And this is really difficult. You can't really see this on an MRI. I only see it because we're looking right at it. So this can progress over time. So this is similar to what happens when we have a bubble, but now the bubble has split away from the labrum. So now I'm pushing between two. There's a big tear in the labrum. The cartilage is really starting to pull more away from the bone. If we look more towards the top of the socket and I push on it, there's a big flap of the cartilage. So we see it's torn off and flapped down. So this is progressive damage from a tear to a little bit of loosening of cartilage off the bone that's not really torn to starting to see the cartilage tear down and away. And what you don't want to see is this. When you look at the socket and you pull, and there's a huge flap of cartilage and a raw area of bone. Because that's the march to arthritis, and those are the things that you really can't fix. So as we talked about it, what do we do? So what we figured out is really important. It's important to fix the tear because that's what hurts, that gives you the pain, but it's also really, really critically important to fix what caused it, and that's the shape of the ball and socket. So where we are is we're outside the socket, so the labrum's here, inside the joint's here. So this is the prominence of the rim, and this is like shop class in high school. It's woodworking. So what we're going to do is take a little bit of that prominence of the rim off slowly, so little pieces at a time. And what we want to do is uncover it to a natural shape of the socket so that it no longer overhangs. So once we like what we've got, now we've got to repair the tear. And so we're able to do this still through these two incisions. What you'll see is this little absorbable anchor being pressed into the bone. And right into the area where we've removed some of the socket, we put that anchor in. We make sure it's not into the cartilage. And then we have some nice suture attached to it. And with that suture, what we're going to do is pass that through the labral tissue and repair the tear. And what's nice is you can do a lot of this work, even though the hip is deep, through two small incisions. And what's important with the tear is really to restore the integrity of that seal between the labrum and the cartilage. So what you can see here is the rim's been trimmed on the top. This is the inside of the socket. We're passing the sutures through the labral tissue, and then we'll tile that back together. And you'll get a nice seal between the labrum and the cartilage. So now we're pretty happy. We're high-fiving each other. We've fixed the tear. I think we're pretty good. So you can see here, there was a tear here. So now we've fixed that tear. Watch out for your motion sickness, sorry. We fixed the tear. Now what's above it is this, we still have this loose bubble of cartilage. You kind of see where there's no tear between, I'm going to back that up for a second. There's no tear between the labrum and the cartilage, but it still moves. And so what's happened here is I removed a little bit of this overhang. So this is the socket that's been trimmed away. We've got a little knot there where we've repaired the tear, but now we don't have a tear between the labrum and the cartilage, but there's this loose area between the two. And so, you can't actually sometimes repair these little areas of loose cartilage or this early cartilage damage. And what you'll see is if we go and pass the suture through the same way, the suture could go up into the cartilage and the labrum, and we pull that bubble up back onto the bone. So we're really trying to take out or take away any of this early cartilage damage and repair it back. So we think we did a pretty good job. We got the socket taken care of, and we've got the labrum repaired. But the problem is if we leave the ball, it's an issue. And so here's a similar picture. The socket's out here. We've removed some of the bone. Here's the labral tissue. We've repaired it all. But watch as I try, and I've let the ball fall into the socket. Now watch as I try to bend the hip up and in. What you're going to see is this ridge of bone try to get up into the socket. So I'm pushing up, and we get stuck there. And so that's that bump or the hump. And as I really try to move the hip in and out, internal, external rotation, that ridge just doesn't quite fit in there. So we're going to go back to woodworking. We're going to go right around the area of the hump, and we're going to just start taking away small areas of the bone progressively so that we remake that nice light bulb appearance around the socket. And this is more the artistic portion of it, or for anybody who's sitting there watching it, the most boring portion of the case, and they're like, why are you still doing that when there's one little thing off there? But this is the artistic portion that you're trying to make look just like a perfect light bulb. so you can recess this bump, and it doesn't come in and hit or damage what you've repaired on the labral and the cartilage side. You see, this is when you say you thought those shop classes were never going to help you ever before. So once we're done, we put the two together now. And so this is going to be the picture of the final product. So we've removed a little bit of that overhang here. Here's the labrum. You'll see sutures in the labrum that have repaired it. The ball is in the socket, and here's that area where the bump once was. And what we'll do is we'll bend the hip all the way in. So you'll see there's a nice seal. We've reconstituted the seal. Here's where the bump's no longer there. And as we move it up, there's a nice recess, and the hip's able to move and rotate in and rotate up and in without hitting the ball on the socket or crushing the labral tissue in between. And what's really nice about being able to do this arthroscopically instead of through an open procedure is you can watch this. You can really see it move well and see the finished product and make sure there are no little areas that hang up or get caught, because oftentimes there are, and oftentimes you go back and just take a little bit more of that bone away. And so what we've gone from is this kind of oval shape to now a more light bulb shaped appearance, and we've kind of resected that to a more round appearance. So we can't fix them all. It's like anything, and sometimes you get labral tissue like this and it's just totally destroyed. If you put a suture into it, it'll go right through it. So you got to take it out. And so what you're left with is the same picture we were looking at. So here's the socket. We've trimmed off the overhang of the socket, made a concavity in the ball. But what you can do is you can make a new one. And so either with your own tissue or with the cadaver tissue, you can sew in and reestablish a labral tissue that seals the ball and socket back together to protect what cartilage you have left. So, what we've come to find out and know, and what is an innovation, is that we've actually figured out these little subtle problems, and we're trying to catch them before the hip really degenerates. Because what we know is that once you start to lose the cartilage arthroscopically, you really don't do as well. We really can't help you as well over time. And there's a threshold with the amount of cartilage that you lose of what we can treat arthroscopically. There's a threshold when you lose it. The scope's not going to help you at this point. You can take off all the bone you want. It's not going to help the space that you've lost. And I think we're really uncertain. We don't have the studies to know that with the way we re-sculpt it and the way we reestablish the seal in the hip, are we truly changing people over time? Are we really preventing them from getting arthritis? And we don't know that. We don't have the long-term studies that show that. But I think if you think about it, and if we really improve the mechanics of the hip by the way they're shaped and the way the hip moves and the way it functions, and we restore that seal and protect the cartilage, we're certainly protecting the cartilage over a longer period of time. We just don't know yet if we're preventing arthritis. We think so, but I will find that out in the coming years. Thanks.